Assalamu alaikum and very good morning to all of you. Welcome on a Saturday morning. It's wonderful to see you all here. We have an exciting session lined up, which is going to talk about innovative tracers, treatment modalities, and we're excited to welcome you all to this session. So the format we're going to follow is we'll have some talks. They can be interactive, but we prefer to keep the questions for the end of each talk. Some of our speakers have to leave, so we will do a short break after each talk and allow a few questions. So right now, I'm going to introduce our session chair. Our chair is Dr. Ahmed Qureshi. Most of you are very well aware of Dr. Ahmed Qureshi. He doesn't need any introduction, but for the sake of formality, I'm going to introduce him. So he's held various roles in PIAS over the years since 1990. He was one of the people who introduced PET-CT in Lahore, in Pakistan. And currently, we are pleased that he is a consultant at Shaukat Khanum, Lahore. Dr. Ahmed, if you would please join us. And now I leave the session in his very capable hands.
Thank you. Let me introduce the first speaker of the day. As already Dr. Amna said, she doesn't need much introduction anyway. So she is currently the head of the division of nuclear medicine and PET-CT at Inmol Cancer Hospital, Lahore. She is one of the leading nuclear physicians of her country and has a vast experience in general nuclear medicine, PET-CT, and theranostics. Sorry, we have got a call from Dr. Adnan. Maybe he's around. Her specific areas of interest are teaching and training. Her academic goals are to share her knowledge and experience not only in the form of interactive sessions but book publications and as well as the current compilation of their endeavor. She is committed to her field, and dissemination of knowledge is something that motivates and energizes her. She has got multiple manuals and books to her credit, including nuclear medicine and practice guidelines, a differentiated thyroid cancer, and atlas of PET-CT on oncological indications. I welcome her. Please, Dr. Fatima.
Thank you very much for such a detailed and nice introduction, Dr. Ahmed. And Assalamu alaikum and good morning to all of you present here. I would like to thank Dr. Amna in particular for inviting me yet again and for a very lavish dinner. The credit goes to both Dr. Amna and I believe Dr. Sadaf. And we really enjoyed ourselves last night. Thank you so much. So let me begin. And my talk is going to be about FAPI-based theranostics, where we are at and where we are heading. So this is going to be the layout of my talk, FAPI concept, because I think most of you sitting here are still not very familiar with it. Then diagnostic role of FAPI, and it will include research studies as well as a few interesting clinical cases, followed by therapeutic role of FAPI, again, including research studies and a few clinical cases. So FDG, as we all know, is the most widely used radiopharmaceutical, but not without its limitations, which are high physiological uptake in normal tissues, low uptake in some tumor types, lack of specificity, because the uptake, as we all know, is seen in infection and inflammation. So coming to the FAPI concept, what is tumor microenvironment, or TME as it is called? Well, it is a heterogeneous system composed of extracellular matrix components, immune cells and fibroblasts, and all of these contribute to the complex mechanism of tumorigenesis. And I look at this diagram, it seems a bit complicated, but it will clarify your concept. This is how the tumor microenvironment looks like. So what are CAFs, or cancer-associated fibroblasts? Well, these are activated fibroblasts highly prevalent in the tumor microenvironment of many cancers. This is what they look like. So these CAFs express FAP, which represents a pan-tumor target. FAP targeting molecules plus radionuclides, gallium, lutetium, actinium, bind to this target, resulting in imaging and therapy. Okay, what is FAP then? Well, it stands for fibroblast activation protein, and it is actually a transmembrane glycoprotein overexpressed on the surface of activated fibroblasts, including CAFs, in approximately 90% of epithelial-derived tumors. Now, this is a beauty because we are all familiar with PSMA and we are familiar with somatostatin receptors. And as you all know, PSMA on prostate cancer cells and somatostatin receptors primarily where? Neuroendocrine. So, is FAP expressed on all fibroblasts? No. It is highly expressed on activated fibroblasts only and not on resting fibroblasts. So, the next question obviously comes to mind. Do activated fibroblasts occur only in tumors? Quickly. Early morning, I want to make it a bit interactive, though I have just 20 minutes to finish it. Yes, you're right, because they are present in benign conditions with tissue damage and chronic inflammation. What about FAP expression in normal tissues? It is low or absent in normal tissues. Again, this is something that makes it superior to FTG. So does this make FAPI more tumor specific than FTG again? It does. How many for it does? I'm sorry to say you're all wrong. Okay. So no, because FAPI uptake is seen in all sites having activated fibroblasts like post-surgical wound healing, bone degenerative diseases, bone fractures, and reactive lymph nodes. But the interesting thing is that this uptake is less, much less as compared to the uptake in the tumors. Okay. All right. So what is FAPI, or fibroblast activation protein inhibitor? It is a novel class of ligands that targets the high expression of FAP on the cell surfaces of activated fibroblasts. Its first clinical use has been reported as early as 1994. Why FAPI is an attractive imaging agent as compared to FDG? Because currently, as we all know, FDG dominates the imaging scene, but FAPI might be a good candidate to dethrone the reigning king. Why? Number of reasons. Due to faster kinetics, imaging as early as 10 minutes can be done. High image contrast due to low background in normal organs, due to the low expression of FAP in the normal quiescent fibroblasts. Consequently, it is able to visualize tumor stroma formation as small as 2 to 3 millimeters. And finally, FAPI PET is independent of blood sugar levels. This means no extensive patient preparation is required. No fasting is required. So FAPI PET may be more sensitive than FDG PET for detecting small lesions. Lesions or tumors with negligible glucose metabolism, such as pancreatic cancer, cholangiocarcinomas, and certain sarcomas. Lesions in brain, oral mucosa, and liver. And scans as early as 10 minutes post-injection, lack of fasting requirements, or the need to withhold insulin/steroids makes FAPI PET easier to perform, particularly in the diabetic and pediatric population. So look at these images. They can further clarify your concepts. These are MIP images. And what do they show you? Physiological distribution of FAPI. And interestingly, you don't see any uptake in the brain, in the liver, in the spleen, in the gut. So let's see where uptake is actually present. Intense uptake in kidneys and bladder, because obviously that's the route of excretion. Low uptake in lacrimal, salivary, and thyroid glands, as well as muscles and oral mucosa. And variable uptake in pancreas, the yellow arrows, do you see? And in the uterus, you can have intense uptake or you can have negligible uptake in the uterus. And like I said, no uptake in brain, liver, spleen, colon, breasts. Okay, so preliminary evidence has generated a raging scientific interest in FAP as the next billion-dollar pan-cancer target. Now, gallium-68 labeled FAPI is most widely used, but F18 labeled FAPI is also an attractive option. Why? Because of the larger batch size, longer half-life, 110 of FTG as compared to 68 of gallium, enabling transport to satellite centers, lower positron energy, leading to better spatial resolution. So here's a long, long list of FAPI traces. I'm not going to confuse you with them. Suffice to know that FAPI-04 and FAPI-46 are best because of their high tumor uptake and high tumor to background ratio. Okay, so efforts to design FAPI ligands with an improving binding affinity, enhanced stability, and optimized pharmacokinetics are underway. Rapid clearance from tumors remains a significant hurdle, and strategies like albumin binding conjugates aim to improve this. Coming to the second part of my talk, diagnostic role. I hope the concept is quite clear to you by now. Okay, so the journey started with this study by Loktev et al. It was a proof of concept study held in 2018, and they first demonstrated high lesional FAPI uptake in 3 patients only. Subsequently, this was followed by a landmark study that was published in JNM in 2019, and it included 80 patients in 28 different tumor types. And this study showed that tracer uptake is highest in sarcomas, cholangiocarcinomas, esophageal lung, and breast cancer. So now these are the images from that study, and they were declared as SNM 2019 Image of the Year. They are demonstrating uptake in 12 tumor entities. And this was obviously published in JNM in August 2019. So here's a systematic review, and this was published in Feb 2023, comparing FAPI and FTG PET-CT in abdominopelvic malignancies. It included 13 studies and 473 patients. So what did they conclude? That the detection ability of gallium FAPI was significantly higher than that of FTG. Another updated review published in Diagnostics in April 2023. And here are some cases from this review. Case 1. Now, the first image is going to be an image of FTG PET-CT, and the next one of FAPI PET-CT. So keeping that in mind, kindly look at these images. 42-year-old woman with biopsy-proven gastric adenocarcinoma. So FTG PET-CT shows no abnormal FTG uptake in the primary lesion in the stomach. Let's see if this works. Yeah, see? You see? No uptake in the stomach. Whereas FTG PET-CT reveals what? Intense tracer avid mass lesion in the stomach. And it also reveals a tracer avid lesion where? Here. So this is the liver, right? And this has resulted in upstaging the disease as well. So moving on to case 2, a 51-year-old woman with biopsy-proven right breast cancer. What do you see on the FTG PET-CT images? Mild tracer avidity in the primary breast lesion and in these axillary lymph nodes. And what do you see on the FAPI PET-CT? See? Intense tracer uptake. Where does this go? Yeah, here. And you see intense uptake in the axillary lymph nodes as well. So moving on to case number 3, 47-year-old woman, known case of ovarian cancer, status post-surgery and chemotherapy with rising CA125 levels. And FTG PET-CT shows no significant FTG uptake in the liver, whereas FAPI PET-CT shows intense uptake in the liver, suggestive of liver mets. So I think in the interest of time, I'm going to skip this head-to-head comparison, and I'm going to move to the takeaways of the diagnostic role. Okay. So FAPI is more sensitive than FDG for the detection of primary tumors and METs due to high expression of FAP in gastrointestinal cancers, female cancers, head and neck cancers, sarcomas, and urothelial cancers. You see the list is quite long. Peritoneal carcinomatosis, particularly the omental cake pattern, intrahepatic and extrahepatic HCC. However, all is not so hunky-dory. There are certain limitations regarding radiolabeled FAPI, high rate of false positives due to inflammatory processes, though less evident than FDG, like I said. False negatives can result from low expression of FAP in the tumor, small lesion size, lesions near the physiological uptake sites. And there are certain limitations regarding the research studies that have come up so far. Several studies have not used histopathology as a standard of reference. Most studies have enrolled small number of patients and are retrospective in nature. So coming to the third and the final part, which is the therapeutic role of FAPI. Well, DOTA chelator in the molecular structure allows the coupling of FAPI molecules with either alpha or beta emitters for therapeutic purposes, making FAPI a potential novel molecule of the century. So this is a very comprehensive review that summarizes the results of preclinical and clinical FAP-based radionuclide therapies published in JNM in July 2023. And takeaways from this review, well, most studies have used beta emitters. And overall, the FAPI therapy appears safe with few toxicities. Repeated therapy has also been found to be feasible and safe. Efficacy. Early studies have reported disease progression or stable disease. Recent studies have reported partial response, particularly in sarcoma patients. However, a complete response to FAPI therapy has not been documented. So another systematic review, and this was published in Feb 2023. And the aim of this review was to gather all the known literature on FAPI theranostics. 8 studies were deemed suitable. Let us have a look at the characteristics of these 8 studies. All patients were selected after failure of previous lines of therapy and submitted to compassionate use of radioligand therapy. There was a decent safety profile overall. As most patients were terminal, progressive disease was the most frequent outcome, followed by stable disease. Pain medication was greatly reduced with a significant improvement in quality of life. Most papers, as you can see from the table, were produced in Germany, followed by India, Iran, and Turkey. A total of 74 patients were evaluated, 22 thyroid cancers, 16 breast, 11 pancreas, and so on. Now, where do we go from here? So I'm going to share with you some very recent data. Dr. Shazia is here. She's come all the way from Islamabad to deliver her talk. Okay, welcome, Dr. Shazia. And this now review by South African researchers on FAPI theranostics was published in March 2025, mind you, this very year. And they concluded that current data are very promising and FAPI theranostics is poised to become a cornerstone in the evolving landscape of nuclear medicine. Now comes my favorite slides, because this talk was delivered by none other than Professor Richard Baum, where 19th ICRT in Feb 2024, and he presented data on FAP-targeted radiotheranostics for the treatment of 19 different adenocarcinomas and sarcomas. 4.5 years clinical experience and outcome in 70 patients. I will not be going into the details, but just to give you an idea, 70 patients were recruited, 54 underwent therapy with lutetium, yttrium, and actinium FAPI. Response to therapy was determined by molecular and morphological imaging, as well as tumor markers, and the results were very encouraging. Therapy was well tolerated with mild side effects only. Efficacy, partial response in patients treated with tandem or combination yttrium-90 and actinium FAPI, Best therapeutic effects were observed in combination with immuno and chemotherapies. 2 complete remissions were seen in case of ovarian and colon cancer. I believe I have one of the cases I'll be showing you. Very promising overall survival, that is 9.5 months, was seen in end-stage pancreatic cancer, where you all know the prognosis is very dismal. So, 19 distinct malignancies from this very data, as you can see. The highest number treated were those of pancreatic cancer. And what do we know about prognosis? Like I said, the prognosis is very dismal, and the 5-year survival rate is just 10%. And as you can see from this pie diagram, that a total of 54 patients were treated. And he used various combinations, but the commonest was lutetium and actinium. Okay. And I'll be showing you cases from this data. So case 1, primary breast cancer with disseminated mets, treated with just 1 cycle of FAPI. Let's see what happens. This is prior to treatment. Look at the extensive metastases and see what happens after 1 cycle. Okay. Moving to case number 2, ovarian cancer, treatment-resistant, extensive lymph node mets. This is the case I mentioned earlier. See these chains of lymph nodes in the abdominopelvic region. And this patient at 9 months after FAPI, at 12 months after 1 cycle of FAPI, and at 18 months after 1 cycle of FAPI. Can anyone tell me what this is? Mera time na khatam ho jaya, but just to keep you people awake. What is this? Is this the part of image? Then it was the camera, because I happened to take these pictures while sitting in the audience. Okay. All right. So what do we see here? Patient remained in complete remission for 2 years post first FAPI cycle. Amazing, isn't it? Okay, this is the last case, case 3, metastatic colon cancer. Now, this patient received a combination of 3 cycles of FAPI plus FOLFIRI. Now, the first set of images show partial remission after the first 2 cycles. And what do you see after the 3rd cycle? Complete remission. And this is actual data from Professor Baum's research. Okay, now those of you who are sleeping, please wake up, because this concerns all the nuclear physicians who are currently treating DTC. FAPI therapy in radioiodine refractory DTC, that is in differentiated thyroid cancer. Now, this pilot study was published in Thyroid in July 2022. 15 patients were recruited. Primary endpoints were thyroglobulin and functional imaging response. TG levels decreased significantly after the treatment, and the therapy was found to be safe and effective. And most importantly, it opens up a new avenue for such patients who have exhausted all standard line of treatment. Now, all these papers are available on the net. And if you intend to start utilizing it, which we at Anmol are hoping to do in the very near future, you can find all the relevant data. Okay, so this is now the same group, but very recently published in JNM in June 2025. And they are now aiming to analyze the long-term outcomes. 73 patients, 65 received monotherapy, 8 patients received a combination of lutetium/actinium FAPI. And the primary endpoints were progression-free and overall survival. And conclusion, therapy showed promising safety and efficacy with a progression-free survival of 29 months and overall survival of 32 months. Mental maths करें जल्दी से, 32 months is 12 3s are 36. Almost 3 years. देखा ना मैं Okay. FAPI therapy in sarcoma patients, heavily pretreated. Again, data published in June 2025 to evaluate the efficacy and safety. 10 patients who received 4 treatment cycles, and the primary endpoints were the same, that is progression-free and overall survival. Therapy was very well tolerated, and partial responses were observed in a significant portion of patients. So I have come to the key takeaways. I can relax, and you can too. Combination therapy with chemo and immunotherapies may enhance overall treatment efficacy by disrupting the tumor's trauma, potentially improving drug penetration and immune cell infiltration. Therapeutic isotopes so far used have been mainly beta emitters. However, alpha emitters could find an even more fitting role in small and aggressive lesions because of their high linear energy transfer. However, several challenges remain, including PAP heterogeneity, establishment of standardized imaging protocols, and dosimetry optimization. So to conclude, gallium FAPI outperforms FDG in detecting cancer across multiple cancer types. Currently, FAPI theranostics appears most promising in advanced sarcoma, breast, thyroid, and pancreatic cancer. No significant adverse effects prohibit administration. Most of the studies showed improvement of symptoms at best. However, it should be noted that patients receive this therapy quite late for compassionate use. Therefore, we cannot exclude a better outcome if the treatment is administered at an earlier stage. Moreover, it is critical to collect more evidence and design appropriate, large-scale, prospective, and randomized clinical trials, maybe in non-terminal patients, to gain a better understanding of FAPI's exact role. So, we need to align our expectations with reality. And how can we do this? Basically, two ways: improve your reality or lower your expectations. Thank you. So I think I can take a few questions.
Okay, we have got a full house here. I think a couple of questions will be.
Yes.
So if there are any quick questions from Dr. Arzu, we can take them.
You can.
I hope you've not been sleeping, because no question means कि ऊपर ऊपर से गुजर गया है या.
Thank you.
अच्छा.
I have a question.
Yeah.
Thank you, Dr. Arzu, for a comprehensive and informative first talk.
On
I have
FAPI. Even for my PGRs and my colleagues, this is something new because we've not yet started it at Enmore. Yeah.
I have a basic question regarding this FAPI concept. What is the exact mechanism for FAP and CAP in targeting the tumor tissue?
Okay. Have I not clarified it in my earlier slides? Okay. So I think what you basically mean is that this radionuclide is going to go into the cancer-associated fibroblasts, not into the actual tumor cells. So how is it going to target them? Well, have you people heard about the crossfire and bystander effect? See, so these fibroblasts are surrounding the tumor cells. When the radionuclide is going to reside in the fibroblasts, through crossfire effect, it is going to target the nearby tumor cells. And what is the bystander effect? Where through production of free radicals and stress signals, it is going to affect the nearby tumor cells. And there's something very important as well. How can it enhance with chemotherapy and immunotherapy? Combination therapies का भी मैंने जिक्र किया है. वो कैसे होगा? मैं थोड़ा सा डॉक्टर अजरा के सवाल को एलेबोरेट करती हूँ, क्योंकि ये मुझे बड़ा इंटरेस्टिंग लगा कि रेजिस्टेंट केसेस, टर्मिनल स्टेज केसेस, उनके अंदर आप कंबाइन करें, जैसे मैंने आपको कोलन कैंसर का दिखाया, फॉल फ्री के साथ आप फैपी दे रहे हैं. होता ये है कि ये जो आपके फाइब्रोब्लास्ट हैं, दे आर सॉर्ट ऑफ फॉर्मिंग अ प्रोटेक्टिव मैश अराउंड द ट्यूमर सेल्स, बिकॉज स्ट्रोमा है ना ट्यूमर के इर्द गिर्द. तो जब इनको आप टारगेट करेंगे, तो देन योर chemotherapy drugs will be able to penetrate the tumor cells more easily. ठीक है? I hope I've been able to clarify this. Any other question? Yeah.
I think any more questions you can ask over the cup of tea. We move on towards. Thank you so much for your nice.
I think, when are we going to be served tea? Because I didn't have my breakfast. Dr. Amna? No, after 3 talks. 3 talks के बाद तो चाय बनती है ना?
ठीक.
Okay, अगर उन्होंने पिला दी तो उस दौरान I'm there to answer all your questions, right? Thank you so much.
So thank you so much. Next speaker is Dr. हमायूं बशीर. उनका कहना ये है कि सारे लोग जानते हैं, इसलिए मेरे इंट्रोडक्शन की जरूरत नहीं है. अगर किसी को कोई क्वेश्चन हो, वो ये भी आखिर में पूछ सकते हैं आप.
अस्सलाम वालेकुम. Dr. Ahmed Qureshi said exactly what I was hoping. It's one of the prime things of nuclear medicine that everybody knows everybody. So that's, it's a thing for newcomers. Okay. See the slide.
Meanwhile, just couple of things. पाकिस्तान, मिडल ईस्ट, आजकल यूके, तो इनका जो है ना ये मल्टी क्या कॉन्टिनेंटल ये आदमी है.
Thank you. Okay, I'll be talking about FTG PET-CT in bladder cancer. The idea behind this talk was because we are using it in our clinical practice, and at some stage it was thought that it's not usable because radiotracer FTG is excreted to the kidneys and the bladder. So that's why an application once considered infeasible. Now, in addition to that, the FAPI train is arriving very fast, so we need to use it as well. We've got more reasons now. Okay, so bladder cancer, it's the 10th most common diagnosed malignancy. Quite a few tumors are identified at early stages, but still 20 to 30% can be muscular invasive, and then they have a very aggressive outcome, poor outcomes, and they have a propensity for involvement into extension of the nodes, which of course has an adverse impact. And the staging through conventional means of the nodal involvement has its limitations, and that's where molecular imaging with FDG or any other tracer comes in. So essentially, where radiology becomes unclear, we clear the things. Now, this is the way things are practiced in Britain, in the NHS, evidence-based. This is a guideline from 2022. There's a combination of experts from Royal College of Physicians as well as radiology. And then these things are put together with evidence, and then recommendations are made how they are used. So this last document was issued in 2022. It's due to be revised next year. And the current recommendation stands that for staging in the setting of proven bladder cancer invasive, and if there's a high risk of metastasis, that's how you select the cases through MDTs, and that's where it's applicable at the staging level, and is restaging for treatment response, and when there's suspected recurrence of the disease on conventional imaging. So these are the potential current applications. Now, I've just started. I just looked at this, the recommendation that's being used. I looked around for any what you call comprehensive articles, and this is what I got, a narrative discussion. And it's a very busy slide. Nobody can read it. It gave me a headache as well. And this paper actually had multiple other tables. So don't focus on that. Just focus on this thing that there's like data from 2005 to 19. There were 23 studies in which 14 were about staging, 6 on restaging, and 3 involved both. And the data is all over the place. The sensitivity is from 33 to 100%. Same as specificity, actually, from 17% to 100%. Positive and negative predictive value, again, a wide range in the. So it's all over the place. That's the reality. And within this big reality, there is clinical application. And then now you understand what the recommendation in that UK-based guideline was. After this, so this was actually conclusion of that very narrative description. It has an incremental role. Standardization, they actually propose a very complicated system at the end of the article as well. So they're hoping there should be some standardization which involves the tumor size, nodal involvement, SUV values, and then post-neoadjuvant what you call changes. They suggested a scoring system in that, and of course the standard recommendation that there should be more randomized trials into it. But this was enough. The paper is good enough to give you the idea that how it is being used and what the data is from all over the world. So after this, I came across an article from Seminars on Nuclear Medicine, which are always very good. But that article essentially said what the previous article said, that the data is all over the place. It can be 100% in really well-selected cases. But if you start doing it too much, then of course you just lose all your sensitivity and specificity. So from this very good article, I just picked up the clinical cases. So in this case, you can see there's a 71-year-old man, a newly diagnosed case. This was done for staging. So they have a locally advanced tumor here on this MIP image you can see. And there's this big diverticulum, in which the tumor was. And this bladder had multiple diverticuli. And when you will come across more and more bladder cases, you will see that how common the diverticuli and how they develop these tumors. And in this MIP image, this blue arrow shows one of the diverticulums on the right side, which was just a diverticulum. It did not have a tumor. But this diverticulum, which was involved, was locally invasive, and it was also involving the sacrum. So it was extending posteriorly. However, there were no distant mets, apart from such a complex disease in the pelvis. But the case was rendered inoperable. Another case from the same review paper. In the bladder, the tumor is actually appreciated as a filling defect. The urinary activity helped to identify that thickening is within the wall, which was a primary tumor. And basically, the second thing which was picked on this scan is a colonic tumor. So patient actually had two primaries. This is in the aging population that we come across in UK. It's one of the fears that you have to always look around for second primaries. You miss them and they get actually caught in the audits, and it can be very problematic. So here it was, apart from the primary tumor, there was involvement of a colonic tumor as well. Now, this is a case with extensive disease. It's in the ureter. There's multiple bony involvement and extensive nodal involvement from pelvis up to the neck. So basically, it mapped the entire extensive disease. This is an 81-year-old man for staging. Yeah, here the tumor is actually in the ureter. You can see it in the right ureter. That's the tumor, and there are nodes along it, and no distant metastasis. This is the article from, this patient actually had two scans. In the first scan, you can see the tumor in the right kidney, right renal pelvis. And this patient was actually staged. That was a localized disease, and patient had underwent nephroureterectomy. And later, patient developed recurrence with metastasis in the abdomen and up in the lungs as well. So, that's what we had it in the indication that in select cases you can stage the disease, and then of course you can follow up after treatment. Treatment was based on a scan which did not have metastasis, but the nature of the disease was such that it was aggressive. Initial treatment was not good enough. Now, some real cases from our hospital. 59-year-old male patient with history of bladder TCC. On follow-up, conventional workup showed some equivocal lesions in the lung and possible liver lesions. So patient had a first scan. The primary, actually, since we can't see the primary, we support that the primary cannot be identified. And that's not the purpose of the scan fundamentally. But there were no metastases. Later on, 10 months later, primary still, we're not commenting on that, but patient actually developed pelvic nodes. And this incidental focus in the thyroid was also identified. It was also present previously. And of course, the nodes were taken as bladder cancer involvement. Thyroid was sent for ultrasound to assess for potential sinister lesion in the thyroid. This is another case, an 86-year-old male patient treated for bladder cancer in 2023. On one of the follow-up CTs, patient actually had pelvic nodes and a very sclerosed skeleton. So this actually, started the what you call cascade of looking for prostate cancer. TCC was not the issue. So then they had the PSMA scan after that. PSA level was 13.5, and PSMA scan was negative in the skeleton. So once, the more you get into it, because there was faint uptake in the prostate, few nodes which are even fainter than the prostate itself. So they were not convincing for coming from prostate. And of course, the skeleton, the PSMA scan did not help, and the bone scan was also negative. By the way, this is very interesting. When you come across these things in MDT and urology, oncology, everybody's there, and somebody will say, let's do a bone scan before walking on a very complex path. So they did that, it did not help. So you have to walk the complex path. So with this PSMA not helping the situation or directing towards a prostate primary, an FDG scan was done. So I've just put this PSMA again. This is the spine. And the FDG scan actually showed these multiple nodes. which were not PSMA positive. So these were attributing towards the bladder cancer. And the skeleton also had focal lesions. Nothing to justify the very, generalized sclerosis, or but they were bone lesions which were attributed to bladder cancer rather than prostate. So, you have to do multiple things to get one from one end to the other. And we had a similar couple of cases some time ago of prostate, and this was the shape of the spine, and PSMA was negative. And again, the oncologist said, "Can you please do a bone scan and reassure us that it's not going to, look hot," which actually helped. So this is actually, we end up calling it unexplained fibrosis of the marrow, which has happened somewhere in the process of the disease, and no tracer. Maybe FAPI might get there, but at the moment, and secondly, the disease itself is not that bad as the CT scan. Okay, now into this area of role in treatment response. This is a very complex paper. I'm very happy that Dr. Nausheen Fatna will be covering this topic. And I just again picked the things which I could easily explain. So we have these criteria for response assessment, which got really complicated once we got into the world of immunotherapy. We had seen that very simple flare phenomenon on bone scan. This is really complex flare phenomenon. Anyway, this is a very recent paper in which they actually, copying from the applications in melanoma, they looked at 3 different ways of assessing immunotherapy response. So they've used it in bladder cancer. So that's the reason that I'm quoting this paper. So these are the definitions of these criteria. We are not going to get into that. Dr. Nausheen will cover that. And again, a very busy table, but basically they were able to establish that using 3 different criteria, they were able to identify overall survival and progression-free survival. The conclusion point was that complete metabolic response could be evaluated pretty well by all 3, methods of evaluating response, while the percimate was actually better at differentiating between those who had stable disease and progressive disease, and that's where it's useful. And the conclusion is that early response to immunotherapy as assessed on FDG is a strong prognostic factor, so it has a good application for treatment response in bladder cancers. And this percimate criteria is probably the best because it helps to differentiate between progression versus pseudoprogression, and that's the most challenging area. Now, last case from the practice that we have a patient with history of TURBT, soft nodules along the posterior aspect of the bladder, which were seen to be growing on CT scans, and they were not very typically metastatic. So in the MDT, it decided to do an FDG scan, and you can see that these were 2 hot spots. Soft tissues are positive here. Additionally, there were focal spots along the epididymis and a focus spot in the prostate as well. And they actually had a pretty extensive discussion. One of these soft nodules was biopsied, and it turned out to be granulomatous inflammation. And for the first time in my 20 years of practice, I came across this term BCGitis. And so that's where it is going. Clinically, patient did not have any sort of symptoms of infection, but it was basically these growing lesions which actually prompted it. But this is the sort of concept looking at it that there can be BCGitis because of the BCG treatment. Now, once we came across this case and I had to prepare for the talk, I looked further into it. That's a pretty important thing, by the way. So this is a paper which from Italy, I think, they had looked into this thing, and it's an established, apparently the oncologists were familiar with it. They never mentioned it in nuclear medicine. Now we know, and hopefully each one of us, Joanna, we can be more careful about it, because the more bladder cancer we'll do, we'll actually come across it. So, and this is they had actually defined a criteria that patients, they present as fever investigated, and if these features are there, a fever, dyspnea, cough, because there could be, chest symptoms, there's a possibility of BCGitis. You've got more evidence, you've got CT evidence for it, then it's likely, and if you can actually prove it on histopathology in the lab, then it's definitely BCGitis. But there's good series around it. And there are a couple of published cases of FDG BCGitis as well. This is from France, I think. A 61-year-old patient who actually underwent an FDG scan for fever of unknown origin. He had a background of treatment with BCG vaccine for severe bladder. And this, you can see this miliary distribution of nodules, which were FDG avid. So this was considered a case of BCGitis. They couldn't have the histopathology proof, but clinically that's how it was concluded and treated, and it had a very good response on follow-up PET CT scan. Unfortunately, patient developed some neurological symptoms as well, an abscess here and some leptomeningitis, which is biopsied, and it was concluded to be pre-granulomatous, and it was again connected to BCG as a case of BCGitis. This is the second case that I could find, and this was again dissected on FDG PET CT. History of bladder cancer with fever of unknown region. Workup done. Patient had these lymph nodes, a nodule in the lungs, and patient was culture positive, and they actually treated the patient with the standard anti-tuberculosis medication, and the patient was sort of cured. This is a systematic review from 2020. And they looked at BCGitis and its impact, and they actually came up with the that it can occur quite soon after, or it can be a late presentation, but it has something to be looked into with that history. So past history, of course, is important. And there are two ways of looking at it. That if there's lung or liver and bone marrow involvement, which can occur earlier, there's less likelihood of a microbiological evidence. While it occurs late, then there's a greater chance of a microbiological evidence as well. So in these cases, you can see that it can be a clinical diagnosis, and you treat it and see the response, or if you can get a tissue biopsy, a tissue evidence for granulomatous disease and TB as well. So this is quite interesting. Now, to conclude, it's always good to conclude with NCCN guidelines. This is the current 2025, and the recommendation is actually it's all based category 2B, which means not evidence strong enough by randomized trials, but good enough that everybody agrees and nobody disagrees. So it's basically approved for staging, restaging, and follow-up in T4 and metastatic disease. So it's case to case, mostly coming from MDTs, close interaction between conventional imaging team, oncologists, of course, the primary treating team, and the nuclear medicine team to actually utilize it. So the take-home message is that we should look at our data, all the centers in Pakistan. I actually came across one paper from Afiri. I'm not sure if anybody is here from there. They actually published that it was the 6th most common sort of in their list of PET scans they have done. That was I think by 2022. So we all departments that are doing PET would have bladder cancer cases in this database. We can always look back and see how the cases were selected. And most of these cases will have, of course, conventional imaging, then PET CT, and some tissue diagnosis. That's how that big complex initial paper I showed you, which data was all over the place. So we should also come up with our own data, see how it looks, and hopefully it should be the same like what's world over, and then we can plan further things. And with FAPI coming up, there'll be more good use of new traces as well. Thank you.
Thank you, Dr. It was a very nice talk. Personally, we don't see many urinary bladder cancers here in Pakistan going for FDG.
Yeah.
And usually, whenever we are like looking at an FDG image from bladder cancer, our concern is more like is there any metastasis present elsewhere?
Yeah.
And the MRI actually is like dictating what's going on inside the pelvis. So how do you compare the findings of FDG versus MRI, which is superior?
Yes. Well, actually, first thing is of course CT, then MRI. In the R urology MDT in Canterbury, it's basically when CT MR is not giving the answer, which is more common than we would expect. That's where FDG comes in. And in staging cases, what is happening is because removing the urinary bladder is a major undertaking. So once our surgeons have started seeing the cases they want to, before they go in to do that, they would like to have a clearance. So that's why more staging is done. And even in that review, there were more staging cases. In a setup like Pakistan, it's very important because over here, the kind of complications or the kind of care required after cystectomy is a major issue. So, I think surgeons, once they know what can be utilized to make sure that you are picking up the best cases, that's very important, because going by the principle of no harm, that's very important. And that's where, and I think that's the best bit of molecular imaging anyway, that you actually make sure that anybody who does not need to go into a major procedure should be avoided. And then, of course, there's a whole battery of other things that the oncology and the Radong team can actually offer. So that's important. We are able to help those cases. And as you said, CT and MR are mostly done. And honestly speaking, most of radiology colleagues are very happy because they have come to learn the limitations of MR thanks to molecular imaging.
Thank you.
Yes, please.
In Karachi and the AKU, the Ziauddin, and of course, that is a busy the public sector and the private sectors. The mindset has been changed, and the most of the urologists now they have the indications of the FDG PET scan as on the baseline. That the two purpose that's for the staging and as well as to see the response evaluation. It
Exactly.
makes like more easier to get the response. This is that is the one. I mean, the comment which I would look to add. But I have a one question. The recommendation of the FDG PET CT in the UK, you have been doing so. So it is basically the contrast enhanced CT or like the without contrast
No, it's
FDG
without
PET CT?
contrast. So over there, CT is not done with contrast.
That's my main
Yeah.
concern.
So, Dr. Mayo, years ago in the US, we would actually catheterize the patient. What about at your center? Do you do delays or do you catheterize?
That hectic review paper, they actually noted all those things. So the way the practice is quite variant over the place. Some people catheterize, some people give diuretics, some don't. At our center, we don't. We try to keep it things simple because we say that looking at the bladder is not our purpose, and we actually looking everywhere. And as Dr. Qureshi said, most of the cases will be where they have a CT and MR, so they know where the gray area is. And this point that Noshin raised about doing the baseline, that's very interesting. 3 cancers, RCC, HCC, and something like this, where FDG was not indicated, and you start doing it complex cases. And everyone said, why didn't we do the baseline? You want to do a baseline because you have to have a reference point somewhere. And that's how most of these infeasible malignancies are getting into it. And it's important that places like ours, India and Pakistan and China, which has such a large number of patients, that data is important because we can actually go out and show where it's useful. But this practice variation is now it's being documented everywhere. Just to close, like recently a paper has been published in JNM from US mapping the variation in the reporting of PSMA scans across the continent, which is huge. It's in every country. So more and more is happening, but there's more and more talk about to harmonize it. The first impact is to identify and document the lack of harmony which is existing. Thank you.
Mostly for my PGRs because you showed 2 very interesting sites in 2 of your cases. I believe one was in the renal pelvis and another one was in the ureter. So we need to assess them very carefully. And then again, there was a focus in one of the epididymis.
Yeah, exactly.
So these are areas you tend to overlook, especially the pelvis and the ureters, thinking that, these are the routes of excretion.
We go through that review article, the bladder starts from the pelvis. So kidneys beyond, higher than that.
Yes.
So that's how, because, I was actually surprised, why is it starting from the ureter? And then I came at, oh God, it's basically the same, structure that's going down. So thank you.
Thank you, Dr. Hamayoun. I would like to invite Dr. Muhammad Adnan Saeed. He is the chair of this session. Kindly please proceed. Dr. Muhammad Adnan Saeed, his MBBS Masters, FCPS in Nuclear Medicine with gold medal, PhD, CHP. He's director of Sinam. Sinam is the first nuclear medical center in Pakistan back in 1961. So it is almost 55 years old and center. Okay. So he is the director of Sinam, Lahore, also the visiting professor at Shifa Tamir Millat University, Islamabad. He's a recipient of Journal Berkey FCPS Gold Medal, I think, in 2009. He's the only one, उसके बाद किसी को नहीं दिया उन्होंने. And also PAC Performance Gold Medal in 2016. Dr. Saeed serves as an examiner and supervisor for FCPS and supervises MPhil, MD, and PhD students at multiple institutions. He is a certified ISO 9001-2015 auditor for the health sector and has authored 24 national and international publications. A former General Secretary of PSNM 2019 to 2021, he served on the editorial boards of PGNM, JRMC, and reviews for journals including PGNM, JCPSP, PGMR, and the Journal of Cancer, Biotherapy, and Radiopharmaceuticals. Thank you so much. Uh, he was a little bit diverted to the wrong place. Otherwise, he was here at 9 o'clock. Thank you. Next, Dr. Shazia Fatima. She is Director General of Nuclear Medicine and Oncology Setup. I invite her for her talk. Thank you. She is going to talk about changing paradigms in treatment of differentiated thyroid cancer. She has got a long list, I believe. अगर इनकी मैं इंट्रोडक्शन कराने लगूं तो 20 मिनट तो उसमें लग जाएंगे. तो
Thank you
but
very
anyway,
much.
as I
Dr. Ahmed और आपने you said that cinema was the first center in Pakistan. मैं आपसे ये expect नहीं कर रही थी. AMC Karachi was the first center in Pakistan in 1960.
Tell us
First nuclear medicine.
North कह लीजिए. Thank you for correcting me. Dr. Shazia ka introduction. She is sorry.
Time चलना शुरू
Nuclear
हो
physician with working experience of 30 years.
गया. आगे बड़ी लंबी है.
Dr. Shazia Fatima, a nuclear physician with working experience of 30 years in nuclear medicine in various national and international nuclear medical setups. ये 30 years से ना age का पता लगना शुरू हो जाता है. Worked in Nuri, in Mole Hospital and Kiran Hospital. Currently, she's working at DG Nuclear Medicine and Oncology setups. She's heading like 20 setups in all over the country. And she's member faculty of CPSP and board of studies of Pias University. Thank you.
Thank you so much. Or 21 centers, because we have started functioning in Azad Kashmir as well. So that is our latest center. Uh, uh, so the topic I was assigned was the changing paradigm of treatment of thyroid cancer. So in between, the new ATA guidelines came. So my job was pretty easy, because then I had to look for the paper. Now the guidelines have everything in them. Since I took everything from the ATA guidelines, so I don't have any conflict of interest. So just to give an overview, that in currently in 2020, this paper was published, and about the global burden and trends. And it said that there are about uh, total of 600,000 patients in the world in 2020, and it was projected that they will increase to 761,000 in 2040. So, and this increase in the burden is because of diagnosis and incidental finding and all that. And similarly, in Asia, when we talk about Asia, the burden is from 2.5 to 7.5 patients per 100 million, per 100,000. So this is rising disease in every region. Since we have 21 centers, so I'll be briefly talking about the data of our centers. From 2019 to 2024, we saw 3,552 thyroid cancer patients, and out of them, 78% were females and 22% were males. Thyroid cancer is not one of the commonest cancer in totality, in not 10 more common cancer, but in females it came at the 10th number in our data, amounting 2.1% of the patient in 2024. So when I went through the data of Shaukat Khanum, from 1994 to December 2024, and the total patient which were seen were 1905, and it was 2.9% of the total patients. Patient population. So we have similar data in Pakistan. So in September, we had this 88-2025 guidelines, and to go through these guidelines, one must remember that now they have categorized as strong recommendations, conditional recommendations, and also good practice statements. And to add to it, they have actually narrowed the scope of this guidelines, because now they are only talking, they're just talking about the DTC. They are not talking about the nodule assessment in this guidelines. So learning objective is basically to summarize major changes, because only 11 minutes left. So I will just go through the important things and then understand the updated recommendation and apply new guidance and molecular testing. So the high level changes which we see in all 84 recommendation which came out in these 88 guidelines, there was a shift towards individualized risk adapted decision making and de-escalation where required. Then there was clearer recommendation on extent of surgery and based on the risk. And then they refined the indicators for radioactive iodine therapy, and more selective use was recommended in especially in low and intermediate risk. And there was integration of molecular testing and genomics to guide management and targeted therapy. And there are expanded guidance on survivorship and quality of life and follow up in the studies. So the one thing which is added, and which is the first thing they talk about, is about the data, which is diagnosis, risk, benefit assessment, treatment response assessment framework. And throughout the guidelines, at the initial setup, and then after follow-ups, and then deciding about the therapies in refractory cases, and then the second therapy, in all these things, you see these data frameworks. And they're quite nice, because they give you a flow how to treat your patient and how to assess and manage your patient. So when we talk about diagnosis and staging, the new thing is it that they are emphasizing on the high quality neck ultrasound and selective cross-sectional imaging for known aggressive features. So the emphasis on the ultrasound, then they use of molecular testing for indeterminate nodules only, and also to inform surgical planning and later on systemic therapy options. And updated staging approach integrates dynamic risk assessment post-operatively. So the pre-operative evaluation, what we should have a pre-operative neck ultrasound to evaluate the cervical lymph node. This is a strong recommendation. And then ultrasound guided FNA of sonographically suspicious lymph node. This is again a strong recommendation. And lastly, the addition of FNA TG washout in the evaluation of suspicious cervical lymph nodes. It can be performed in select preoperative patients, but interpretation may be difficult in patients with intact thyroid gland. I have never done it. I don't have any experience of it, but it is mentioned in guidelines. So I think we should be looking for it, what it actually means. But this is a conditional recommendation. So they also talk about the active surveillance. Once it is diagnosed that we have a low risk papillary thyroid cancer, active surveillance is may be offered as an appropriate management option to some patient in T1A and 0M0 papillary thyroid cancer. And also they mentioned in active surveillance that ultrasound guided percutaneous ablation may be considered as an alternative to active surveillance or resection for these T1N0M0 PTCs in selected patient. And the shared clinical decision making between patient and clinical team regarding the risk and benefit of the surveillance and this ultrasound guided percutaneous separation approach is recommended as well. So again, talking about active surveillance remains an option for small papillary cancers. There is a guidance to reduce intensity and duration of surveillance. How frequently we call patient for the surveillance for truly low risk disease to avoid unnecessary anxiety and cost. And there is emphasis on the use of shared decision making when choosing surveillance versus immediate surgery. So, active surveillance, there is a paper which they referred, which was published in 2024. Again, it talks about doing the active surveillance and PTC. Jumping on to the surgical management, for small, low risk DTC, lobectomy remains an option, and total thyroidectomy is recommended for higher risk features only. And then they talk about prophylactic central neck dissection based on the surgeon's judgment and risk features, and emphasis on multidisciplinary decision making and patient-centered discussion on risk and benefits. Throughout these guidelines, this patient-centered thing and risk and benefit is overarching. So this table is from the same guidelines, and it just tells us that lobectomy when the disease is unilateral and T1, then lobectomy should be done, and then total thyroidectomy in most of the cases, and central neck dissection depending on the risk factors. So lobectomy preferred in less than 2 centimeter nodule. Completion thyroidectomy is more selective, and central neck dissection is clear avoidance in N0 stage. So these are the paper which were mentioned, and one should go through it, that whether to do total lobectomy or lobectomy or total thyroidectomy. Then again, data framework for initial therapy. We diagnose, we have the AGCC staging, the histopathology, the clinical information, then we do risk assessment, and then we have TG, anti-TG at 6 to 12 weeks, and then treatment decision, and then assessment 6 to 12 months later. So this is a very important table, and this is actually if you go through that, you will likely to have most of the information about the management. This is actually from in 2015, we had the 3-tiered system for risk assessment, but now they have gone to 4-tier, and in this risk stratification system, the histopathological features, the number of cervical nodes, post-operative imaging, and serum TG and anti-TG are included. This is a very comprehensive table, and we need to go through it very carefully to decide what our patient should have for the treatment. So in this, they are still using the TNM, AGCC, UICC, TNM. All know what is the difference between the 7th and the 8th edition. Then they are talking about the genomic changes and combination of event associated with DTC. This need to be carefully selected for genetic testing, because there are so many genetic tests offered, but we have to weigh which to do and when to do. So talking about radioactive iodine therapy, it is recommended selectively reserved for the patient with higher risk of recurrence and persistent disease, and avoid routine radioactive iodine use for many low-risk patient. It should be individualized and discussion for intermediate risk cases, because now we have intermediate to from low to intermediate and intermediate to high category. So in those two categories, the radioactive iodine has to be individualized. When used, adapt dose to disease extent and goals for the remnant ablation, adjuvant therapy, and therapeutic intent. So, remnant ablation is not recommended routinely for total thyroidectomy patient with low risk. Radioactive iodine adjuvant therapy may be considered after total thyroidectomy in patients with low, intermediate, and intermediate high risk of recurrent DTC. Radioactive iodine adjuvant therapy is recommended routinely after total thyroidectomy for patient with high risk and patient with an initial diagnosis of DTC with distant mets, we have to go for radioactive iodine therapy. So these are the doses recommended and suggested in the guidelines. So we have to tailor according to the risk we have for a patient and according to the stage we have. So response assessment, as we all know, is excellent response, indeterminate response, biochemical incomplete response, and structural incomplete response. And the response criteria eventually depends on the type of treatment you have, whether the patient underwent total thyroidectomy or is it post hemithyroidectomy. And in all these the response stages, they are also talking about what should be our TSH goal. So it should be within normal range when the response is excellent. Similarly, in indeterminate, TSH should be within normal range, reference range, and in biochemical complete response, TSH should be below normal reference range. So post-operative risk assessment and follow-up use dynamic risk stratification based on the response. And we have updated thyroglobulin threshold and imaging triggers for recurrence workup and in individualized TSS suppression based on the recurrence risk and comorbidity. This is a very interesting sort of table they have given for the dynamic risk stratification from low, how we proceed, whether it is excellent response or indeterminate, and how much based on the data, we have seen that how much patient is going into these responses. So post-therapy thyroglobulin measurement should be a standardized assay, and then measure serum TG on thyroid hormone therapy, and then measure it after 6 to 12 months. And measurement of serum TG on thyroid hormone in patient after lobectomy is debatable because initial follow-up is not recommended routinely, and this is a conditional recommendation. So de-escalation is also recommended, in which that they say that after the hemithyroidectomy or total thyroidectomy with response or without response, we have to actually tailor our treatment. So data framework, after you have given the treatment and there is a persistent or recurrent disease, then you have to think about after initial diagnosis and then TG, ATG level and treatment decision, you have to go for surgery or local therapy or radioactive iodine, and monitoring is with TG, TGAB. Uh, so in advanced and metastatic disease, there are expanded algorithms for molecular targeting testing. But I have shown you the table, but you have to select according to your patient which molecular target you want to see. And there is clearer placement of systemic targeted therapies and kinase inhibitor for progressive and radioactive iodine refractory disease. And there is encouragement to enroll the appropriate patient in clinical trials. Then this is the trial when this is the framework for the therapy of radioactive iodine resistant DTC. I don't have time to go through it. Then molecular testing, a little bit on that there is a broader recommendation for molecular profiling in advanced disease and selected preoperative cases to inform about the management. And the molecular result can influence extent of surgery, radioactive iodine, and eligibility for targeted therapies, and recommendation to interpret molecular test within the multidisciplinary team of Hussain Akare. And then this is the framework for second line therapy. Then then they talk about the survivorship and patient-centered care. So this is the new section in the guidelines, and they focus on minimizing over-testing and supporting return to work, fertility, and thyroid hormone optimization, and they recognize and address patient anxiety. These are the comparison which you will see anywhere. I don't have time to go through it, but practical takeaway is that we should avoid one size fits all strategy. We are not doing it since 2015, but it is more emphasized in this. Use molecular testing selectively to guide management, limited RAI to patients likely to benefit, and personalized surveillance intensity, engage multidisciplinary team, and prioritize survivorship issues. Thank you so much.
Thank you for a comprehensive talk. There must be a lot of questions, but we are sorry. I mean, one question can be taken, but we have got already behind the schedule now.
Everyone.
So
बस ये थोड़ा सा फाइन ट्यून किया है उन्होंने और emphasis अच्छा है, but now the take home message for these guideline is कि 2015 में जो चीजें हमने देखी थी वो अब with the impact इसलिए आई हैं because they have data to support for what they have seen in 2015.
You feel what guidelines can they emphasize molecular testing should be selective. Was there some overuse of it?
Uh, they said that use is एक तो ये है कि indeterminate nodule.
Yeah.
उसके बाद when you're talking about targeted therapies,
Yeah. Then you should. Yeah. Right. Thank you.
thank you. Thank you so much.
Our next speaker is Dr. Nosheen Fatma. She is a professor and head nuclear medicine theranostics department, Dow University of Health Sciences, and visiting consultant in nuclear medicine PET department of Khan University. And she'll be talking about the role of FDG PET-CT in assessing response to immunotherapy, a clinical perspective. Dr. Nosheen, please.
Assalamu alaikum and good morning, everyone. And thank you very much for your introduction, Dr. Ahmed, and the both of you. And I must say that is only the one remarks and the comments for the Dr. Ahmed Qureshi, because I have a very naram garam the training program with Dr. Ahmed Qureshi. This is for the beginners because I learned a lot. I just want to quote, if the timer is only, just give me the, that is the 10 seconds. हुआ ये था कि जब हम इनके पास थे तो हमें एक प्रेजेंटेशन के लिए सर ने कहा, एंड ड्यूरिंग द नाइट टाइम हमने जब उसको ट्रांसफर किया तो वो डिलीट हो गई. एंड आई टॉक टू डॉक्टर अहमद, तो डॉक्टर अहमद ने कहा कि अगर दूध फर्श पे गिर जाए तो व्हाट विल यू डू. That was a turning point, and I made the presentation overnight. But ये कि that point मैंने ये learn किया कि कभी भी आपके जो senior कह रहे होते हैं तो it should be taken as a the positive way, क्योंकि उसके बाद I turn out to be more resilient, and ये कि कभी भी किसी senior का मैंने बुरा नहीं माना, and I keep on going, and it is a turning point of my life. Thank you, Dr. Ahmad. So now I'm officially starting my presentation. So thank you, Dr. Amnasan and Dr. Hajra, for inviting me and such a lovely hospitality, and I'm extremely grateful. The topic assigned to me is quite challenging. The assessing the response to immunotherapy, a clinical perspective, what is the role of FDG PET-CT? So keeping in a view of the presentation, I must the focused particularly that is immune checkpoint inhibitor, what is the scope, challenges, unconventional novel responses, morphologicals, and the PET criteria, what are the modifications and what are the consensus released in the guidelines in 2022, and the recap of the presentation. So as you know, the immunotherapy has considered as a major revolutionary change in the clinical oncology. And it is basically meant for to strengthen the body immune system against the cancer cell. And what are those immune system? That is cytotoxic T lymphocyte, protein 4, that is programmed cell death protein, and the programmed cell death protein 1 ligand. Remember, these names are very important because immunotherapy is against the proteins and the markers. So what are the mechanism of the action of strengthen the immune system? By administration of certain antigens in the form of the vaccine, cytokines, and the lab-based monoclonal antibodies. And the major breakthrough is the immune checkpoint inhibitor, that is ICI, causing the reactivations of the immune system to recognize and kill the cancer cell. So this is the theoretical background. So at the cellular level, it is quite interesting. As you know, that is during that is in the newcomer in the MBBS, because in our time point that it was not the case. The mycobacterium also creating the envelopes. In the tumor cells, they also create certain envelope which is causing the resistance to the body immune defense system. They're going to inhibit the T cell to causing the cytotoxicity and immune defense to the cancer cells. So what are going to do in the immune checkpoint inhibitor? They are going to inhibit on the anti-PDL and the PDL1, which is causing the inhibitions to the T cell activations. So in that way, they're releasing the brake on the T cell, and the T cell becomes activated and recognize the cancer cells, and they kill the cancer cells. So the mechanism is quite precise. So that's the reason why it is more effective as compared to the conventional chemotherapy and the targeted therapy. So the clinical use, I'm not going to the detail. It is widely used in the metastatic cancers and the local, the recurrence as a mono and the combination therapy. But the greater efficacy in the low burden tumor, because it targets the tumor cells before it develops the unfavorable microenvironment, because the tumor cells tends to develop the resistance to any therapy. This is the normal behavior of the tumor cells. So challenges being the clinicians, nuclear physicians, and the radiologists, the major challenge is to see the response evaluation. It is not the conventional chemotherapy and the targeted based response evaluation. This is something different and which is unconventional response. What are those? These are the pseudoprogressions, hyperprogressions, dissociated durable response, and immune related adverse events. The major challenge is when the patient's having the worsening of the scan on the follow-up scan. That is the first interim scan. So the challenge is whether to continue the treatment or stop at this certain time point, because the patient might land up on the remission or the progressive disease. This is very challenging. So where we can take the help with the clinical symptoms and the clinical stability of the patient. If the patient is clinically worse, so it is suggested and recommended to discontinue to the treatment on certain time point. If the patient is clinically stable and the durable, we take the benefit of the doubt and the continue the treatment, and the 1/3 of the patient usually land up with the remission of the disease. So this is a major challenge, and which is the creating these certain guidelines to revise and giving the modifications. For the purpose of the simplicity, these are the 4 criteria which is summed up by the recent guideline. And on the left side, of course, this is the left side on the hand. This is the complex pattern, and this is the clear-cut picture. These are all 3 sets, the baseline, interim, and the follow-up scan. The first is the pseudoprogression. Pseudoprogression, when there's a worsenings of the scan in the interim and the remissions on the follow-up scan. Hyperprogressions, when there is a linear worsenings of the scan findings. It is a clear, straightforward. Dissociated response, again, the complex one. It is a mixed pattern. The some tumor showing remission, some progression, disappearance of the lesion, and on the follow-up scans, that is the remission of the scan. And on the last one is a durable response. There is a linear decline of the scan findings. But believe me or not, in the real world, in the day-to-day clinical practice, these are not the clear-cut findings that we are going to report. It is always challenging. Every next patient is a challenge to us. The pseudoprogression, this is a case of the non-small cell lung cancer. on the right lung, and you can see on the interim scans there is a significant increased metabolic tumor volume and the some size progression, and the patient was clinically stable, so the treatment was the continued, and we can see the remission of the disease. By definition, pseudoprogression is basically the paradoxical worsenings of the scan findings with the clinical stability of the patient, and the patient should continue on the treatment, and the follow-up should be done to ascertain the response 4 to 8 weeks, but not later than 8 weeks. And it is usually happens 4 to 6 weeks or much longer if the patient is on the combination therapy. And the plausible explanation why it's happening because of the priming effects of the T cells, delayed activations of the immune response, and the local tumor edema. And it is more commonly reported with the anti-CTLA4 as compared to the anti-PD1 and the PD-L1. And it is considered as a better prognostic sign. Life is not straightforward, so we have to face the atypical findings as well. So this is the atypical presentation of the pseudoprogression. The patient is adenocarcinoma right lung. On the interim scan, we can see there is a remission, the partial response. And on the follow-up scan, there is unexpected increase in the metabolic tumor volume. So by definition, the pseudoprogression is usually happens on the interim scan. So there is the delayed presentation of the worsenings of the scan findings. The patient was clinically stable, and the another indication that the patient was responding to the immunotherapy, there is a diffuse uptake of the colon. So at this time point, we labeled the patient as pseudoprogression, and the decision was to continue the treatment, and patient land up with the remission of the disease. Hyperprogression is a worsenings of the scan findings and in concordance with the clinical deterioration of the disease, and it is usually happening 9 to 29% of the cases, worse prognostic sign, and the termination of the treatment is recommended in order to avoid the treatment-related toxicity and mortalities. And it is usually happening with the risk factors like the elder age group, some family genetic amplifications, and epithelial growth factor receptor aberrations. This is another clinical case of the hyperprogression. There is a clear-cut worsening of the scan findings of the serial imaging. Another complex pattern, dissociated response, which is called as mixed response. It is due to the heterogeneity of the tumor microenvironment, and it is also considered as a better prognostic sign. And in this scenario, that it is recommended give the benefit of the doubt and continue the treatment. This is one of the clinical case of our hospital. The patient was renal cell carcinoma, status post left nephrectomy, and he was presented with the peritoneal mets. And also there is a FDG avid partially calcified thoracic nodes and the low FDG avid lytic met and the left scapula. On the interim scan, we can see there is a partial remission on the metabolic peritoneal disease, but surprisingly, there is a progression of the lytic mat on the left scapula. The patient was clinically stable and he was continuing on the treatment, and you can see complete remission of the neoplastic disease and the partially calcified stable nodes, which is labeled as the infective nodes. Durable response, that means the remission of the disease, and it may persist even discontinuation of the treatment. And depending upon the treatment and the tumor types, the incidence is 10 to 25%, and it is more effective 2 to 3 times higher than the conventional therapy that favors the efficacy of the immunotherapy as compared to the conventional therapy. This is another clinical case of our hospital, the right breast cancer with the contralateral axillary node and the right common iliac nodal mat. On interim scan, the distant mats is all gone, and on the follow-up scan, complete remission of the disease. So now come to the response criteria. There are the two response criteria, the based on the radiologist, that is contrast enhanced CT, and the second is a PET-based criteria. So if we rely on the contrast enhanced CT, because of the unpredictable response of the immunotherapy, it takes time to get the shrinkage of the tumor. It is very difficult to label the patient the pseudoprogressions and differentiate from the true progression, and resulting in the premature discontinuation of the ICI treatment, and that is not good for the patient who might get the benefit for the immunotherapy continuation. So the PET-based criteria is more sensitive, but there is a wide range of the criteria, and it is very difficult to select which criteria is better than other. Just to resolve this, there is the general consensus and the comprehensive guideline released major societies of the Europe, America, Australia, and the New Zealand, there is a professional consensus to correctly perform, interpret, and report the PET scan, and particularly for the correct treatment decisions in the continuations of the immunotherapy. And of course, it is not definitive. It is not considered as the one thing that we have to follow, because the field is rapidly evolving, and every day we are coming up with the different articles and the incidents that this is not good, this should be done. So that again, the local variation should be taken into consideration within the multidisciplinary settings. The use of the PET scan, this is another consensus that went to use. There's a general recommendation it should be done before the start of immunotherapy at the baseline, and define your target lesion to follow that with the indicator like SUV max, which is most commonly performed in the most of the center, and the lean body mass, SUV peak, and metabolic tumor volume. The choice is your hospital and discretion of your institute. And during the course of the treatment, interim scan should be done 8 to 12 weeks or 3 to 4 cycles, or even much earlier the latter, depending upon the progression on the morphological, the criteria, or the clinical status. Before the termination of the immunotherapy, it should be done to ascertain the metabolic response, or the restaging after the discontinuation of the first-line therapy, and to start the second-line therapy for any reasons like the immune-related adverse event or any resistance to the first therapy. For the sake of understanding, because there is a table which is very complicated, the criteria, the based on 50 patients, 34 patients, 25 patients. So I just took that is only 3, which our centers is routinely performed. Okay, the one is the ERTC, second is the percent, and the third is the persist one. The target lesion, as you know, the commonly performed SUV, and the percent based on the number of the lesions and the size criteria, and the persist, the lean body mass, it is the formula based, and the number of the lesion. So it is very cumbersome to perform. Complete metabolic response, life is very simple, that is remission of the disease. Partial metabolic response, this is again the formula based. In ERTC, when there is a metabolic regression of more than 15%, less than 25% at one cycle, and when it is from more than 25% regression from the baseline if the cycle is more than 1. Percent, it is subjective disappearance lesion, and in the persist, when there is a more than 30% sum, that means the all target lesion sum, the SUL peak or absolute drop of 0.8 in SUL from the baseline is considered as partial response. Stable disease, when there is a decline of not more than 15% and the progression is not more than 25%, and when they are not fulfilling the criteria. And the progressive disease, when there is a progression is more than 25% and the 20% the longest dimension, and the percent, it is based on the new lesions. In our centers, we are mixing the two criteria. And the more than 30% in SUL peak or the appearance of the any convincing new lesion. So, but whatever the criteria, the one thing is very important, that being nuclear physician, we should be clear and loud enough about the unconfirmed to the confirmed progressive disease to correct decision guide to the clinicians. These are the indicators. I'm just skipping because of the constraint of the time. This is important, the immune-related adverse events, that it has to be differentiated from the progressive disease, and we should have the good understanding what are those that is side effects that it can be happen any time point during the serial imaging. That could be hypophysitis, thyroiditis, and colitis, and it should be incorporated into your report findings and conclusion as well. The recap, immuno-oncology is a rapidly evolving the field, and the major challenge is the response evaluations. And when we rely on the RECIST criteria, the premature discontinuations of the therapy. So being the nuclear physicians, radiologists, this is our responsibility that we should give the clear message to the clinicians about the differentiations of the pseudoprogressions, hyperprogressions, and immune-related adverse event to make the life simple and easy for the clinicians to take the decision about the continuation or discontinuation of the treatment. And it can be only happen when we standardized our protocol nationwide and the comprehensive history of the immunotherapy, that is the type of the immunotherapy, number of the cycle, most receiving dates, and the clinical status of the patient. Thank you very much. This is all about, this is my center, which is established in April 25. Thank you.
Thank you, Dr. Nasheen. Any questions from the audience, please? Uh, Thank you so much. It was a really interesting topic. Next, in PSNM, I believe you will be coming and delivering similar lecture or not? Because I've got questions. Thank you. Okay, right. So we move on towards the targeted therapy cases. I believe there are 5 of them. I would invite Dr. Humayun Bashir as a moderator for the session. Dr. Amina Hassan and Dr. Hajra Ilyas will be like the panelists. Thank you so much. Auntie.
So it's the first case on lutetium dotatate therapy. We had a 45-year-old male who was diagnosed with a neuroendocrine tumor of the pancreas, grade 2. These are the initial CT images, which shows a pancreatic head tumor. This was invading and averting the adjacent vessel, so it was deemed irresectable on the baseline scan. ERCP and metallic stenting of the patient was done, and patient was put on octreotide therapy. However, after 4 doses of octreotide therapy, the patient showed disease progression in terms of interval increase in the periportal lymph nodes. However, the mass remained stable. Patient was put on capecitabine chemotherapy. The follow-up CT scans were stable, so additional 6 cycles were given. Laparotomy and gastrojejunostomy were carried out. However, during operation, it was noted that tumor was irresectable, so patient was proceeded with again chemotherapy for additional 6 cycles. CT scans showed disease progression in terms of interval development of pulmonary nodules. So the treatment was switched to everolimus. Um, on everolimus, again, the patient showed disease progression in terms of interval development of hepatic metastasis. The primary mass also showed tumor progression and started invading duodenum. Patient was then referred for lutetium dotatate therapy to nuclear medicine department. As a part of a baseline treatment planning for lutetium, gallium dotanok PET CT was carried out, which showed that the hepatic metastasis and the primary lesion both were dotanok avid. FDG PET CT was also carried out, which showed that the primary lesion was non-avid. The hepatic lesions were also avid. However, their avidity is less than that of the dotanok. So net PET score was 1. Sorry, it was 2. Baseline blood tests were carried out. They were within the range acceptable for lutetium therapy. Since the patient had well-differentiated pancreatic neuroendocrine tumor grade 2, progression on multiple lines of treatment, avid on gallium-68 dotanok PET CT, ECOG status of 1, labs within the range, therapy was proceeded. The patient took four complete doses. This was the first post-therapy scan, and this was the last post-therapy scan. The first scan showed well-delivered dose to hepatic metastasis and known primary in the pancreas. The last post-therapy scan showed that there was interval resolution of hepatic metastasis. However, low-grade avidity was noted in the primary mass. Follow-up, the patient remained stable on a follow-up. This is a follow-up PET scan after almost a year. We showed the stable response in terms of no evidence of hepatic disease and the low-grade avidity in the pancreatic tumor. Thank you.
Right. So what's the frequency on at what time would? Okay, fine. Yeah, sorry. I was asking present. Okay, so we have got a expert panel over here, and we'll ask them that, what's the plan for follow-up of this patient?
Okay, so we have complete resolution. right? 4 cycles. And actually, I think Dr. Aisha also showed that on follow up, um, continues to stay okay. So, Dr. Hajra, I think this patient was about a year out and there is no disease. So, in terms of follow up further,
So for these patients, what we would do in the NHS is so after treatment, 6 months PET scan, then after 9 months, if they're fine, then we discharge them back to the primary. And then they follow them up with conventional radiological imaging as required. Only if there was concern of progression, only then they would be asked to have a PET CT and then they would be referred to us. So would be a just medicine department.
Yeah, well, that's a very good point. It's kind of reassuring that you send the patient back to the primaries, because it's as somebody observing, because we're not doing these cases directly, one wonders that because these patients has usually are sent to nuclear medicine by the time they're palliative. So in a palliative setting, if you get a almost complete response, it sounds reassuring, but you are still in very, dangerous territory. Uh, so
So
how frequently we get to this point?
well, it's quite frequently actually.
Okay.
So even though this patient had very good response and they had almost complete remission, which a vast majority of our patients there would be stable, and we were
Okay.
happy for them to be stable,
Stable.
because these are patients who were progressing before they had this treatment. And now that if we've managed to stabilize the disease for more than a year,
Yeah.
so we are at a very good point.
Yeah.
And anyways, these are generally slow growing tumors.
Tumors, yeah.
So we were always quite happy to have reached this point and the disease was stable, and we'd be really happy if there was some remission,
Yeah.
and confidently send them back to the primaries. And
Right.
those patients have done really well even
Right.
how many years after.
Right. Okay. So we go to the next case.
So this is a patient, 50 years old male with left lumbar pain. And the patient had a CT chest abdomen done, and that revealed an heterogeneously enhancing mass in the left kidney suprarenal region. And differentials of pheochromocytoma versus adrenal sarcoma were made. Patient had a baseline metanephrine and normetanephrine levels that were quite elevated. So we performed the DOTA PET CT of this patient. And the DOTA PET CT of the patient demonstrate the heterogeneously enhancing left suprarenal mass with multiple bilateral DOTA avid pulmonary nodules. So the diagnosis of metastatic pheochromocytoma was made. The patient was referred to our department for consideration of lutetium therapy. After extensive literature review and intra-departmental discussions, we decided to proceed with lutetium therapy for this patient. Uh, these were his baseline labs just before we started the therapy. His metanephrines were 93 and normetanephrines were 760. So these are his 4 cycles post-therapy, post-lutetium therapy scans, which shows the last scan actually shows some less avidity in the primary tumor. This is the SPECT CT of both the scans post first cycle and post fourth cycle of lutetium DOTA therapy. We did perform the blood tests of the patient after 2 cycles of the therapy. Metanephrines were slightly raised and normetanephrines were stable. Patient remained clinically well. His blood test remained within range during all the cycles. He has been given 4 cycles of lutetium therapy till date, and his recently blood test revealed metanephrine levels of 216 and normetanephrine less than 500. So our question is, what is the future course of treatment? Is there surveillance or further cycles?
Okay, so this is off-label use case to case. So I would like to ask the panel that how easy was to get to this point of using it off-label?
so at Shaukat Khanum, we have to actually follow all guidelines. So as we know, FDA approval is for gastroenteropancreatic tumors. We do have a mechanism in the hospital. If there is sufficient data, there is evidence, we can bring it forth to the medical director with evidence, of course. There's a to and fro And if there is sound clinical evidence, then yes, they do approve. So in this case, there's a mountain of data. We actually consulted colleagues internationally as well for their experience. So irresectable. He's a youngish guy, and there is no other option for him. Um, and we're very encouraged actually. Dr. Muntaha just found out the results of the current blood work, and they show improvement. So we're happy.
I just want to, was MIBG considered as a diagnostic thing at any stage?
No, actually, it was not. So I think
Why was that? How do you
the
skip it?
yeah, the switch that we're seeing is with the availability of DOTA, and then actually, I don't even remember the last MIBG we've done, honestly speaking.
Oh, so you're doing
It,
all
they're all
POs
gallium
or suspected
DOTA.
POs with gallium
Yes.
dota.
Yeah.
Okay, well, that's better than NHS.
So we did, so we did have a discussion about this. So in NHS, what we do is like as Dr. Amna said, it's not FDA approved. It's not even NICE approved to use lutetium dotatate for these patients.
Yeah.
We have only one center there, guys, in St. Thomas's, which we get all these referrals for non-approved indications. So we've done quite a few of these patients, and they've responded quite well. The only thing I was saying is at that point we do an MIBG, and then we do a lutetium, and then we do an FDG PET. Gallium dotatate and FDG PET, and decide which way to go. But because for this patient we discussed that because MIBG treatment is not an option in Pakistan, there's no point wasting the money, and we just proceeded.
And Dr. Raja, do you have any experience from guys of using or having access to F18 DOPA?
No, I'm not while I was there.
That wasn't there. Because, in Canterbury, we had a case in which we actually had done, patient had elevated metanephrine and FeO. We did an MIBG, which was negative. I saw something somewhere around the pancreas, asked for an MRI. Radiology wasn't happy. There was nothing there. The levels were still high, so they repeated a scan. That focus was still there. And then finally, we just said, okay, try to get a DOTA scan or an F-DOPA from London, King's or somewhere else. This was just last week, so we were just hoping. Because in that centralized system, you can't do everything everywhere. Even for a specialized thing, then patients have to go there. And one of these places where Dr. Haja was. Yes, it's quite a kind of case to case. And so it's,
So in the US, yes. So yeah, when I report there, F-DOPA, gallium DOTA, no matter what you want, it's right there. And then we see this dichotomy. So it's actually useful, but we don't have it available here. So DOTA.
DOTA. NOTA is also there. Yeah, that's another. Yeah, exactly. No, we just went for the DOPA, because in the presentation for the endocrine meeting over here in Islamabad, there was a review in which they've compared, and they actually thought that F-DOPA is ideal, but that's very rarely available. So DOTA is definitely more available and better than MIBG. But then, Professor Just Boscom can also show you that if you do everything, then you find a very heterogeneous picture. But this is a good approach that if you have a therapeutic tool in your hand, you just do that so that your options remain. It's not about proving a point where it is avid, it's more about being able to treat it as well. Fine. Thank you.
So for these patients, so in the NHS, obviously, it's all funding guided. So 3 months after the treatment's finished, then 9 months after the last treatment, which is 6 months after that one, and then after that, it's only as required. We wouldn't routinely do their total PET CT to see if they're still in remission.
So the next patient is 60-year age of a female which presented with the history of diabetes, hypertension, and chronic kidney disease. Initially, left breast mass lesion was seen, for which lumpectomy was done, and it was consistent with the intraductal papilloma. After 4 years, my patient presented with the history of constipation and perrectal bleed. Anal mass was seen on the colonoscopy. Histopathology was done, which was consistent with the neuroendocrine tumor WHO grade 1, and the stage was T3N2M1. 8 cycles of octreotide injection was given. Palliative radiation was done to the sacrum. DOTA scan was done, which shows disease progression with the interval development of new osseous lesion, increase in the size of hepatic metastases, and the patient was referred for the lutetium therapy. PET scan was done, which shows multifocal bilobar hepatic FDG non-avid metastases, and the sacral lesion was also non-avid on the FDG PET scan. While these lesions were show significant tracer uptake on the gallium dotatate scan, first cycle was given, which shows good lutetium uptake in the lesions. Cycle 4 was given. After cycle 4, gallium DOTA scan was done, which shows mild decrease in the size in sizes compared to the recent post-therapy scan. Compared to baseline gallium DOTA scan, good response with significant interval reduction in the size and degree of uptake was seen. Fifth and sixth cycles were given. DOTA scan was done 3 months later, which shows overall disease regression. But DOTA scan after 5 months shows interval development of tracer avid abdominal lymphadenopathy, suggestive of progressive disease. Cycle 7 and 8 was given. On the 7th cycle, patient developed abdominal ascites and pleural effusion. So the question is, we have heard about the iodine refractory thyroid disease. Is there any terminology about lutetium refractory disease?
It's very interesting. But iodine refractory is in a very good disease going bad. This is actually bad going worse. So what would you say, Dr. Amna?
So this patient came to us quite sick, palliative,
Yeah.
literally, and she got more than a year of very good return to health. She was living with disease. When she got early progression, getting disease about 8 months after 6 cycles. So this was technically early progression. And so what we observed was when we went ahead with 2 more cycles, we just didn't see that response. And we looked into data, and yes, there is refractory disease.
Yeah.
Dr. Haja, if you would like to comment, it's definitely there, and it's definitely
Yeah,
is
so in UK, we kind of follow guidance. If there is recurrence within or progression within 9 months of your last cycle, that's why we do that 9-month scan. We feel like that it's de-differentiated or it's not going nutrition, it's unlikely to be helpful. Here we took a chance because there weren't many other options.
Yeah.
And because she done so well and she was so close to that 9-month mark, so after discussing with the family and having multiple discussions, we thought we will give it a shot because that was the only hope the patient had. But otherwise, yes, early progression after nutrition, they're unlikely to respond to re-challenge.
Right. And from a perspective as a nuclear physician, because treating thyroid cancer for training and then clinical is different, this is a different ball game, which oncologists are, of course, much more familiar with. I remember we at Shaukat Khanum, we had one thyroid cancer patient who had resectable disease, and we treated him, and he was sort of the tumor, big tumor, was sort of decreasing in size. Everything looked okay, but the nature of the beast is such that when papillary thyroid cancer goes bad, it goes really bad. And when it started getting bad, we had to go back to the oncologist to get and that was the time around when the palliative as a discipline was sort of getting in. So that was essential. And I believe in these cases, palliative is right there, because what happens is that disease, pseudo progression, everything, but clinical betterment gives a lot of hope to the patient and the family, and to keep that thing that we are still in, really difficult area. So yeah, we'll go to the next case.
So for case number 4, we have a 66 years old male patient diagnosed with metastatic castration-resistant prostate carcinoma with a Gleason score of 4 plus 5, total score 9. Status post prostatectomy in 2016, started on hormonal treatment, later switched to abiraterone for progression, stopped in 2020, then switched to enzalutamide. Now this patient developed this really big right shoulder slash supraclavicular region mass, very angry looking, aggressive,
mass to look at in clinic and in department. Histopathologically, this was proven to be metastatic prostate carcinoma. This particular lesion was also given radiation in 2023. Later on, he progressed, and then he was referred for consideration of lutetium-177 PSMA therapy to nuclear medicine department. So this is the baseline gallium-68 PSMA PET CT scan. On the single slice, we can appreciate this huge soft tissue density having some heterogeneous area, and all of this is avid. So this is lighting up. This is PSMA avid, large right supraclavicular region mass with which the patient came for lutetium therapy. Um, as at the time of consideration, his numbers were within range, labs were optimum, so we decided to go ahead with lutetium PSMA. These four serial images show his pictures post therapy scans after cycle 1, cycle 2, and cycle 3. By cycle 3, we can note a drop in his serum PSA level from 23.09 to 9.4, and also we can appreciate an overall regression in the size of this large right nodal mass. So this is a gross representation of what we looked in the clinic and department. So at cycle 1, the thing looks really red, and really the picture is not a complete justification of what we actually had in reality. By cycle 2, we can appreciate there is a lot of healing with a lot of wound sort of dried up, and there is some, blackening of and there is some scarring around the wound. But by cycle 3, this patient unfortunately developed new lumps, which were non tracer avid, and we had to stop therapy there. So this is his scan post cycle 3, CT and fusion image on SPECT. And this right here is actually the new development, which is not showing much tracer uptake. And hence, because of this new development, a new complaint, it was decided to stop lutetium therapy. And case was referred back to medical oncologist. And later on, this patient actually passed away.
So well, this was something like the case I just mentioned, but that was C thyroid. This is odd in itself to begin with, that prostate recurring in the neck, a solitary site. It was PSMA avid. I think that's not a surprise, but the nature of the beast, something which was so odd and which has gone and metastasized so far away, it became PSMA avid. But I think this would have been the clinical outcome sooner or later. So it's one of those cases. And today, when I was looking at the article I mentioned, in which they have established the heterogeneity of use of PSMA, and trying to be consistent and should be consistent. And somewhere on LinkedIn, another guy mentioned, one of the observers mentioned, now PSA has become that hammer that you got in your hand. Wherever you see a nail, you just hit it. So one has to be very careful about it. And because the fundamental from, I think, Socrates, no harm, the small period of, and I think previously these things used to be treated with radiotherapy, you know, they already, so, once radiation was sort of, somebody might suggest, if, somebody like Dr. AJ would have been here, that if radiation had failed, maybe somewhere at that point there was a time to stop. Uh, right, fine. So we'll go to the last case now. Thank you.
So this patient, he was a 67-year-old male patient with prostate adenocarcinoma, Gleason score 9. He had a serial gallium PET CT from the start. He had very avid right internal pelvic side wall and a solitary aortocaval node on the baseline. So he was started on docetaxel, prednisolone, 6 cycle were given, prostate received the radiation. After that, the restaging scan showed progression in nodal and osseous metastasis. He was started on abiraterone and then switched to enzalutamide, and there was PSA and serial scanning was evident of progressive disease. So he was referred for lutetium therapy to us. This was the baseline pre-therapy scan on which there was interval development of diffuse osseous metastasis, pulmonary mets, and nodal disease. So patient had several poor prognostic factors, high Gleason score on the baseline, short PSA doubling time, short progression, like morphological progression was very fast, and pulmonary metastasis, high tumor volume, and patient presented to us with ECOG of 2. He received six cycle of lutetium therapy, and he showed very good response. Like we can see that initially we see the decrease in intensity of the lesion, and later on last 2 cycles there is interval resolution of the lesions as well. So this was the PSA during the therapy. It dropped to 1.9 before the last cycle, and patient remained clinically well. His other labs, LDH, CRP, alkaline phosphatase, they declined over the course of therapy. He did not develop any toxicity. ECOG improved significantly, but the patient died 1 month after the last cycle. So our question is that is pre-therapy cardiac risk stratification is of any importance, or like we should consider it during the course of therapies as well?
Well, I'm not aware of any cardiotoxicity related to PSMA. I don't think that is there.
It's like because of the androgen deprivation.
Yes, exactly. That's what I was coming to. So other factors, all treatments previously given or ongoing, especially hormonal, that can be, a factor to consider, I believe. But would that become a triage point? That
So this was a learning point for us. Phenomenal response, as you
Yeah.
saw. Patient doing exceptionally well, and we're all so happy. And since then, we looked at literature in great depth, and there are now guidelines. There are suggestions. There actually. So all of this stratification should have been done before they came to us,
right.
because when they get androgen deprivation therapy, castration, etc., all of that, it's like a female, that estrogen protection
Hypertros-
goes away. So for the males, the testosterone protection has gone away and they're at high risk. A lot of them have diabetes, hypertension, so they have more than one risk factor on top of having that removal of their hormone protection. So what we're doing now is sending them to cardiology for risk stratification. And our cardiologist was surprised also. They would
Yeah.
send us back and say, lutetium has no risk. And, although if you read the packet insert,
It's
it
a
does say there is a small risk of arrhythmias, but it's the so now we're thinking of the patient holistically.
Yes.
I really feel that the nuclear physicians are no longer just imaging people, or it's so different from thyroid
That's it.
treatment. We have to think of the patient as a whole. There's no point in a therapy giving such results. In the end, we say Allah ki marzi. Yes, Allah ki marzi. But as clinicians, as
At least we should
physicians,
rule out.
we
Yeah.
need to figure out
Figure
what
it out.
other risks. So we are now almost becoming these primary physicians to the patients, and they come to us with problems with other
Yeah.
issues, and we refer them to nephrology, to cardiology, to any specialty that they require. We're there to
Yep.
refer
I
them.
remember Dr. Haja knows Dr. Fahim at Guys he works. So I was discussing him about doing radiation synovectomies. So we're thinking of doing one of those therapies, newer thing which is available. I thought, what about radiation? It's simple. He said, no therapy is simple. You take up a patient and then you don't know what you are going to end up. And he says, then within the NHS system or for that penny system, because all these patients, even in our country, they'll be listed in that one particular hospital. So when the patient will have a problem and something going, haywire from blood sugar, whatever, then they'll require a clinician. And since the nuclear physician was the last person they met, and who was also offering a magic bullet, so you will end up being, the sort of treating physician. So as Dr. Amna said, this is getting more and more wider, where we have to recall all our skills, and then of course keep the perspective, because the problem with therapies at one level is that we already get patients which are depleted because they have had so many treatments, and then they have risk factors. So if we triage too much, then we'll also lose the opportunity. So it's a balancing act.
This is not an exclusion point.
Right.
So for stratification, we need better optimization of their blood pressure control, closer monitoring by cardiology.
Yeah.
There is no exclusion. So for prostate cancer, when we read guidelines and updates, there's literally no contraindication. There is no absolute, because these patients are terminal. The results we're seeing here are nothing short of a miracle, because even the oncologists don't expect this. Nobody expects this. So I think the frontier is going to move. The understanding of the disease is moving. It's evolving. We have to evolve with it, and we have to be a part of those discussions. I think nuclear medicine is no longer an
Oh,
isolated
yes, absolutely.
specialty. We have
It's a,
to be there, and we have to
you have to be
understand.
part of the multidisciplinary workup, and then it has to be done. Dr. Raja, any concluding remarks?
It's about this, or just yes.
Anything?
No, so I was just going to add to this is that, the rest of the therapies, these are patients for prostate cancer. They're mainly elderly men who are anyways at high risk for heart disease.
Yeah.
So it does make sense to have them assessed.
Yeah.
And unfortunately, this patient who's doing so well.
Yeah. And just to conclude it, this is a case patient where there was such a good response, and it has highlighted something which opens up the other Pandora's box. So that's that's the territory we are in. So I think such meetings or interdisciplinary meeting within the hospital, then countrywide, region-wide, that's very important. And I think, Dr. Sheen also mentioned all the complex cases are to be discussed. Data talks about some really beautiful stuff, but it's the patient, and no two patients are alike, actually, right? So with this, we can conclude the session. Thank you very much, everybody.
Thank you.